Okay, when we begin our 10-point must or predictive type of biomechanical examination, which is really an abbreviated exam so that we can do it in a time-efficient manner but still get the most information for our treatments, whether that's a conservative or a surgical procedure that's intended. And the first thing we start with is transverse plane hip rotation. And the first thing I like to do is just get a general idea of total range of motion, and I'm also looking for quantity and quality of motion. Once I've done that, and I've gotten a sense if both hips seem to be symmetrical with the same amount of motion, then I'm going to look at the individual hips. I'm going to start with the right, first with an observational exam, and as I rotate the hip out, I'm actually using the tibial tuberosity as my reference point, and I'm considering that just like the clock hands, that for every 30 degrees would represent a number on the clock. So if I'm able to come out to approximately 11 o'clock, it would be 30 degrees. If I can get to 10 o'clock, it would be 60 degrees, 45 being about the normal, so between 10 and 11 o'clock. Medial rotation, same thing. We're looking at the tibial tuberosity, and we're using the numbers on the clock as an observational guide. Once we've done that, we can do our instrumented evaluation. And the first way we would do it is placing the gravity goniometer on top of the kneecap and holding that stable with one hand. We rotate out and we get the idea of the motion. In this case, we're reading approximately 60 degrees. And then we do our medial rotation, come in, and in this case, reading again approximately 40 degrees. Next thing we want to evaluate is the femoral patellar relationship, and this relationship between the femur, long axis of the femur, and an axis through the patella, and the tibial tuberosity represents the Q angle. And that angle, which we'll measure with our hinge goniometer, in women will tend to be slightly larger than in males due to the increased pelvic width for childbirth, which will naturally give women a slightly higher genu-valgum. For women, we typically talk approximately 20 degrees for high normal. For men, 17, 18 degrees would be a more normal. For this exam, a larger hinge goniometer is more accurate. We have the long axis through the femur, and the other hinge axis coming through the patella. Tibial tuberosity. The angle that we read in this case is approximately 22 degrees, so a little higher than normal, which would indicate that we'll have a little higher knock knee than normal and possibly a little wider base of gait as we see here. And we would do this exam for both extremities because knee alignment is not always symmetrical. You may have a stronger genu-valgum on one side versus the other. The next thing we look at, working down from proximal to distal, is going to be the sagittal plane knee extension. To see if there is any laxity in the knee, we simply place a hand above the patella, holding the thigh down as we elevate the leg. Normally, we may see about 10 degrees of elevation or extension of the leg at the knee. And we always check both sides. And to measure this, we can take our gravity goniometer, and we can measure the angle, and saying between 10 and 15 degrees. And we read approximately 15 degrees, so a slightly high normal. for patients that have greater than 10 degrees, we would expect that they will demonstrate some recurvatus or back knee posture during stance. If they also have a coexisting ankle equinus condition, that tends to further accentuate the back knee recurvatus position. The next alignment we'll be looking at is the possibility of a limb length discrepancy. And for this, the initial portion of the exam involves doing a very simple test called the Alice test. And for this exam, we're going to flex the patient's knee, just lifting, to approximately 60 degrees. And we're going to do both limbs. Very important for this exam to make sure the ankles are close to each other on the same level, that the hips are firmly secured against the chair. Patient may also be totally reclined for this examination, and that the legs are directed vertically and are not leaning either way. Once we've positioned the patient where we feel they're accurately positioned, we can determine if there's a limb length in the tibias where one tibia is shorter than the other by placing a straight edge on top of the tibias and then placing the gravity goniometer. And for normal aligned tibias, they will read 0, as they do for this patient. So we would not suspect any difference in tibial alignment. To determine if there's a difference in femoral alignment, we need to look from the side. And now we're looking to see if the femurs are on the same level when we look directly across. And they appear to be the same. And you would do this from both sides so that we make sure we're not influenced just by the illusion that one's coming out further. In this case, the femurs appear to be in line, so no evidence of a structural limb length discrepancy with the tibias or femurs would be noted. And due to the symmetry, I would not measure for a limb length. However, if I did find a difference in tibial and or femoral length, I would next measure, and to do this we would use a fabric tape measure. We use landmarks where we palpate the anterior superior iliac spine and holding firmly, we come down and measure to the apex, the midpoint of the medial malleolus. If there were a problem with the medial malleolus due to edema or other problems, the apex of the lateral malleolus could be used, but the same reference point would need to be used for both sides. If we're looking to determine whether there may be more of a functional type of a limb length discrepancy, we can take the same measurement from the umbilicus and measure and look for symmetry to both extremities to the medial malleolus. So from the anatomical anterior superior iliac spine, we're looking at an osseous relationship for structural differences into either the umbilicus or xiphoid process a little higher. We can determine if there may be a functional component. This test and measurement can further be done in stance, where we do the tape measure from the anterior superior iliac spine in reference to the floor, which may tell us again if there's a functional or a structural component. Continuing distally, the next measurement we want to look at is the tibial alignment, and tibias normally have a slight bowing. Approximately 3 degrees to 5 degrees would be considered, 5 degrees being the higher normal. And to measure this at rest, and I like to do this measurement both at rest and during stance, we can use just a standard hinged goniometer, and we look at the proximal half relative to the distal half of the tibia. So we place one arm of the hinge goniometer on the distal or proximal aspect of the tibial crest, and the other arm on the distal aspect of the crest. In this case, we read 2 to 3 degrees, and we can see a very gentle, mild bowing, certainly within normal limits. Higher degrees of bowing or tibial varum would influence foot position, and we would expect to see for higher degrees of tibial varum compensatory subtalar joint pronation and foot pronation. The next measurement that we'll look at is transverse plane tibial torsion to see if there's a structural torsion of the tibias. Usually this measurement is within 13 to 18 degrees for the adult. If we see values higher than 18 degrees, it would indicate that the tibia is in a higher than normal externally positioned rotation. And the way we measure this is to actually look at the alignment of the medial and lateral malleolus, and we do the axis of the two. Very important for this exam that we make sure the tibial tuberosity is directed vertically so that we can use our reference. To measure this alignment, we position the torsion goniometer, making sure the cups are directly over the apex of the medial and lateral malleolus. And we read this, and we're reading approximately 13 to 14 degrees. So that would indicate our tibial and malleolar torsion to be within normal limits. Another very easy way to get an approximation of the tibial alignment is to place one thumb on top of the lateral malleolus. The other thumb goes right at the midpoint, the apex of the medial malleolus, and the thumb should appear to be on the same level if torsion is within normal limits. If the torsion had been increased, our thumb position would be changed, where our thumb at the apex of the medial malleolus would be higher than the thumb atop the lateral malleolus. If there was a decrease or a lack of tibial torsion, we would note our thumb on the medial malleolus to be lower than the thumb on the lateral malleolus. Again, it's very important for this examination for the tibial tuberosity to be directed vertical, as that's our reference. The next measurement we need to take is to determine if there's an equinus in which we have less than 10 degrees of dorsiflexion available at the ankle joint. For this examination, we use the base of the fifth metatarsal, or the end of the calcaneus laterally, relative to a long axis of the leg. And for this, the peroneal tendon usually gives us a nice reference that we can use as a surface anatomy marker. And the first thing I like to do is to make sure subtalar joint is neutral to slightly supinated. And we dorsiflex the foot, and we get a sense, are we making an angle past 90, which we'll next measure. If we find the patient has a decreased ankle dorsiflexion with the knee extended, we would then flex the knee to see if we can overcome the tightness once we've removed tension on the gastrocnemius muscle. To measure ankle equinus, need to place one axis along the peroneal tendon. The other line needs to be in line with the plantar aspect of the foot. Holding that, we'll dorsiflex the foot, recheck our measurements and our alignments. And with that, I'm just shy of 10 degrees to determine if there is additional motion with the knee flexed. You can elevate rather than have the patient lying prone. Next we can check position again, and here we find we're still tight still having slightly less than 10 degrees with the knee flexed, which would tell us both the soleus and the gastrocnemius muscle are tight, and therefore we would recommend stretching with both the knee extended and flexed to stretch both muscles. The next measurement to take is the first ray range of motion and the first ray neutral position. To do this, we place the subtalar joint in its neutral position and we grasp metatarsal heads 2 through 5 with one hand. With our free hand, we place the thumb at